High-quality pre-analytical handling of all specimens and nuanced interpretation are essential. Recent development of powerful new drugs, for example, the HER2 antibody-drug conjugates, has shown efficacies in tumor that are HER2-low or even ultra-low.
Hello, and welcome back to the Oncology Brothers podcast. Today, the topic at hand we'll be tackling is HER2 testing in breast cancer space. What used to be rather binary classification, that is positive or negative, has rather evolved into significantly something more profound. That is, what we're using for HER2 status being reported as positive, negative. Now we are also reporting that as positive or low or even ultra low.
It is important to appreciate the shift and these nuances in testing because HER2 has now become not just a classic oncogenic driver, but also a target for antibody-drug conjugates such as Trastuzumab deruxtecan.
We have come to recognize that the biology of the disease is much more complex than we usually recognized before. A number of different new biomarkers have emerged. So essentially, the importance of these biomarkers is that they do have a significant impact in the way we manage patients and we select treatment.
So it is crucial to test for HER2 expression in breast cancer. We can look for the gene amplification by doing in situ hybridization. The other way to do is to look at HER2 protein expression by immunohistochemistry. So by looking at this, we score the tumor cells expression from 0 to 3+. Only 3+ strong staining correlates with gene amplification and thus considered positive. And for cases that are scored 0, but they show very, very weak staining, we call this HER2-ultralow. Recent development of powerful new drugs, for example, the HER2 antibody-drug conjugates, has shown efficacies in tumor that are HER2-low or even ultra-low.
Because some of the new therapies, as you mentioned, for example, in the DB06 trial, also work in patients that are not HER2 3+. They also work in 1+ and 2+, and in the ultra-low, as Gary mentioned. So this concept of moving from a binary result, positive or negative, is extremely important for the community oncology to learn that we are changing.
High-quality pre-analytical handling of all specimens and nuanced interpretation are essential. The first problem is metastatic diseases. Biopsies are always taken from distant sites, multiple sites, bone, liver, lymph nodes, and many of these are very difficult to assess. So unlike the primary tumor, which is much easier to assess, so this would limit the materials that we were able to perform our tests. In clinical practice, of course, we always try to obtain tissue from the most accessible or adequately preserved specimens. Once the specimen is obtained, there are specific things that we need to do or have to observe. The first is to avoid delays in fixation. Secondly, the use of fixative and the duration for the fixation. Overall, pre-analytical errors usually would lead to reduction of the antigen expression, and thus it would lead to false negative results rather than false positive results. So this is particularly important in HER2-low, ultra-low setting, because when they are already very low, if you lost your sensitivity, then it will become decreased from ultra-low to negative.
One of the questions I ask myself whenever I receive a pathology report is, does this pathology report actually speaks to the clinical picture this patient is presenting or not? Because from that moment on, everything I do, it's going to be based on that piece of paper.
So what the roles we play would, apart from giving and very accurate reports, we would also highlight the difficulties and also to understand the clinical scenarios. We can highlight sample limitations and potential errors. We could also bring to our colleagues the possibility of issues related to HER2 heterogeneity and the subtleties of low-level expression.
Oncology is becoming so complex okay, that we cannot manage this kind of disease without help and without discussing this with other people. So I think that the critical key message is that we need to recognize this complexity, the understanding of the disease, the resistant mechanisms, actually leads to one very important concept. We improve patient outcomes.
Why we are doing this is all because there is meaning to it, because there are clinical implications tied to it. Gary and Carlos, thanks so much for both of your insights today. We are the Oncology Brothers.